Hello, I'm Ian Rockett from West Virginia University. I would like to talk to you about work that I have been doing along with colleagues on the relationship between psychological and psychiatric evidence and determination of suicide. It's almost axiomatic that psychological and psychiatric variables feature prominently as determinants of suicide. Far less understood, however, is the role these variables play in the decision-making of medical examiners and coroners when they respectively diagnose and rule a death as suicide, and two, whether the variables are differentially important according to the nature of the suicide method or injury mechanism or cause of death. Evidentiary standards are high for medical examiners and coroners to assign suicide as the manner of death. To show suicidal intent, medical examiners must make their diagnosis based upon reasonable medical certainty, and coroners their ruling against a burden of proof standard of beyond reasonable doubt. I have no disclosures. Suicide is highly susceptible to misclassification under the other manners of death provided for on the death certificate, namely homicide, accident, undetermined intent, and natural causes or disease. In fact, as a generally stigmatized and socially condemned phenomenon, suicide is undercounted in the United States and globally, which brings me to the learning objectives for this webinar. I'm hoping that at the end of this presentation, if you're not already there, that you will be sensitized to the problem of differential suicide misclassification, recognize the differential importance of psychological and psychiatric evidence in the medico-legal assignment by medical examiners and coroners of suicides by method or cause, and finally to understand the need for more accurate data to inform prevention, treatment and evaluation. I study the determinants of suicide determination as distinct from the determinants of suicide. My focus is the quality of suicide data. A perspective or orientation strongly influencing my research is called social constructionism. Social constructionism cautions users against uncritically adopting suicide and other official data at face value. And I'd like to share a couple of quotes with you which I think will better illustrate what we mean by social constructionism, at least in the context of suicide data quality. Facts strongly suggest that the relationship between statistical organizations and the suicide rates they produce is subject to the following principle. Other things being equal, suicide rates vary directly with the degree of professional medical training of the categorizers, the average rate of person hours devoted to cause of death categorization, and the independence of the categorizers from interested parties. Second quote, proper diagnosis of suicidal death rests upon adequate personnel, appropriate legislation, and financial and community support. These quotes may seem overly cynical about the process of compiling official suicide statistics, but I propose that the remainder of my presentation will affirm their continuing relevance and validity. To reiterate, suicide is undercounted, but undercounting is non-random across suicide methods and decedent demographics, with drug intoxication suicides being highly vulnerable to misclassification. Most people are fully aware our country is experiencing an opioid mortality epidemic. However, you may be less aware of the magnitude of the growth. Between 2000 and 2016, there was a more than threefold increase in the drug intoxication mortality rate nationally. In West Virginia, which is experiencing the highest drug intoxication mortality rate in the country, the rate increase was eightfold. Most of these drug deaths involve prescription and/or illicit opioids such as oxycodone, heroin, and fentanyl. When the rate increases are viewed within the context of severely under-resourced and overburdened emergency medical care and medico-legal death investigation system, it is clear there is high potential for misclassification, so that medical examiners and coroners may well be missing many true suicides. Besides highly stressed systems, other forces likely contributing to the undercounting of suicide include 1. Punitive life insurance policy provisions, 2. Social stigma, which means suicide is not a default manner of death assignment for medical examiners and coroners, 3, the substantial decline in the combined clinical and forensic autopsy rate in recent decades. And 4, the fact that most police are not trained in suicide investigation. Indeed, the police usually stop their death investigations when they can rule out homicide. Moreover, there is no equivalent agency to the police in the United States to investigate suicides, despite suicide officially accounting for more than twice as many deaths as homicide. Not only do death certificates provide for recording manner of death, but also for recording the underlying cause, that is, the event that precipitated the death, and any accompanying conditions or comorbidities, such as kidney disease and major depression. Lado Ruzicka and his Australian research team used multiple cause of death data from national death certificates to examine various comorbidities for purposes of predicting, among pooled suicide and accident deaths, that manner of death would be classified as suicide rather than accident. Colleagues and I duplicated the methodology of the Australian researchers to conduct 2 studies in the United States. The first study was confined to males and females, consistent with the demographic domain of the Australian study. This study replication meant we could compare the 2 countries with respect to their capture of physical diseases and psychiatric disorders on death certificates. At the time, both countries registered very similar suicide rates at approximately 12 to 13 per 100,000 population. Since the countries shared similar life expectancies and levels of socio-economic development, there was no a priori reason to believe that people who died by suicide in Australia were sicker than their American counterparts. Australians had higher healthy life expectancy than Americans. A quarter of Australian male suicides and a third of female suicides had at least one comorbidity mentioned on their death certificates. Psychopathology was twice as prevalent among Australian as American suicides, at least according to the data that came from death certificates. In predicting a suicide versus an accident manner of death determination, the relative odds of association between depression and mood disorder were 37 in the Australian study versus only 7 in the US study. These comparative findings prompt this question: are Australian death investigations more fastidious than American counterparts in their post-mortem assessment of psychiatric disorders among fatal injury cases? Our results suggest this is true. However, there is strong reason to believe that the death certificates in both countries poorly reflect the mental state of the decedents just prior to their deaths. For systematic reviews indicate up to 90% of people dying by suicide in more developed countries had a diagnosable psychiatric illness. In our second American multiple cause of death study, in which we compared whites with the 2 largest minorities, blacks and Hispanics, we assumed there was no reason to believe that whites who died by suicide were sicker than minority opposites. Yet more physical and psychiatric comorbidity was captured on the death certificates of whites. Again, differential data quality appears implicated. 8% of US white male suicides had at least one comorbidity mentioned on their death certificate, versus 4% of black and 3% of Hispanic counterparts. Corresponding female figures were 10%, 8%, and 6%. In both sets of comparisons, namely those between American Australians and American whites and the 2 major minorities, there were discrepancies in the degree to which comorbidities of people who died by suicide were captured on their respective death certificates. Viewed collectively, these revelations about health data disparities and deficits augur negatively for the design, targeting, and evaluation of suicide prevention programs and interventions. US blacks have a suicide rate less than half that of whites. In light of previous findings, this gap raised the question that it might be a partial or total artifact of death certificate data for blacks being of inferior quality to the corresponding data for whites. In a preliminary evaluation of this question, we conducted a study in which we compared blacks and whites on the likelihood their pooled suicide and undetermined intent deaths were classified as undetermined. Undetermined is the manner of death category most relatively susceptible to hiding true suicides. In absolute terms, the accident category is likely more important in suicide misclassification than undetermined. Our univariable analysis in this study shows that blacks whose manner of death was suicide or undetermined intent were 2.4 times more likely than whites to be classified as undetermined, suggesting greater susceptibility to suicide misclassification. This racial ethnic association persisted with incorporation of other sociodemographic characteristics into the analysis, and also with the inclusion of the variable psychiatric documentation, yes versus no or unknown. When there was no or unknown documentation of psychiatric comorbidity versus documentation, there was more than 6 times the likelihood of an undetermined classification. Finally, when mode of injury was included in the analysis, the black-white and also Hispanic-white differences persisted, as also did the Psychiatric Documentation Association, albeit the latter association was less pronounced. However, decedents whose mode or mechanism of injury was categorized as less active versus more active were 46 times more likely to have their manner of death classified by medical examiners and coroners as undetermined. Drug intoxication cases predominated among the less active group. In another study, also published in 2010, we demonstrated an overlap between suicide trends in the US and those for unintentional poisoning deaths. Again, these last mentioned deaths predominantly comprise drug intoxications. Taken together, all of the aforementioned studies set the scene for the final study I want to talk about in this webinar, a study published in PLOS ONE in January 2018. This study more directly was concerned with the relative importance of psychological and psychiatric variables in terms of medical examiners and coroners assigning deaths as suicide according to the nature of the suicide method or injury mechanism. More specifically, without strong corroborative evidence, most notably an authenticated suicide note and psychiatric history, drug intoxication suicides may be more susceptible to misclassification under undetermined intent or accident manner of death than were suicides by the two more overt and violent methods, firearm and hanging. Not only is undetermined the manner of death category most prone to suicide misclassification, but it can serve as a window into misclassification within the much larger accident category, the category in which most fatal drug intoxication deaths are classified in the United States. This study tested 2 hypotheses, and the first has multiple parts. Among pooled suicide and undetermined intent cases, medico-legal assignment of suicide manner of death is more likely when A, the injury mechanism or cause is gunshot or hanging suffocation versus drug intoxication, and there was documentation of a suicide note, a prior suicide attempt, or diagnosed depression or bipolar disorder. So that was the first multiple part hypothesis. The second hypothesis was that any observed associations are stronger among drug intoxication than gunshot hanging cases. Our methods, our study was a multi-level, multivariable study. We actually had 2 levels, so we collected information on individual characteristics of the decedents, and we also collected county level data. The individual level data were extracted from the National Violent Death Reporting System restricted access database for the years 2011 to 2013 from 17 states, and the county level data came from CDC, the National Association of Medical Examiners, International Association of Coroners and Medical Examiners, and the County Area Health Resource File. We used a generalized linear mixed model. Our statistical analyses were adjusted for death investigation and system characteristics, death circumstances, blood alcohol concentration, number of other specified drug positives, and such demographic characteristics as age, sex, race, ethnicity, and education. Our study population comprised registered suicides and undetermined intent deaths in the 15 years and older age group with known state and county of death, and we had a bit over 32,000 cases. The Since our study was confined to 17 states, a key issue is generalizability of results. I will now show comparative data in two tables for these states and the nation on population and mortality characteristics and methods of suicide. High concordance across these various characteristics strongly indicates generalizability is not problematic. The age and sex distributions for the NVDRS states and national populations are extremely similar. However, there is overrepresentation of non-Hispanic whites and blacks in the 17 NVDRS states and underrepresentation of Hispanics. The manner of death distributions between the two populations are also quite similar, as are the mortality rates, including the crude and age-adjusted suicide and undetermined intent rates. The same is true for the distribution of suicides by method, but I need to say that if we had really accurate data, I believe that the drug suicides would be relatively more important than one would infer just looking at this figure. In this multi-level, multivariable study, we predicted classification of a suicide versus undetermined intent manner of death for pooled suicide and undetermined cases, in contrast to the 2010 study where the order for the dichotomous outcome variable was reversed, that is, undetermined versus suicide rather than suicide versus undetermined. The data I will present in the next slide are adjusted for the impact of 18 variables which pertain to the demographic characteristics of the decedents, type and accreditation status of the death investigation system, and death circumstances. This table only displays the results for variables concerning the specific hypotheses. Starting with injury mechanism or cause and drug intoxication cases as the reference category, combined gunshot hanging cases were 41 times more likely than drug cases to be classified by medical examiners as suicide versus undetermined. Cases accompanied by an authenticated suicide note were 34 times more likely to be classified as suicide than were cases for which there was no evidence of a note. Although less strong, evidence of a prior suicide attempt or a diagnosis of major depression or bipolar disorder was also associated with a suicide rather than undetermined manner of death classification. So the final thing we did in terms of testing hypotheses was to stratify our data. So we compared drug intoxication cases with the gunshot hanging cases. So when we stratified the injury mechanism or cause in this way, the association with the suicide note was far stronger for the drug intoxication cases, odds ratio of 45 versus a rather lower 8 for the gunshot hanging cases. Psychiatric history was associated with the suicide classification for the drug cases, but not for the gunshot hanging cases. Data deficits pose problems for valid case ascertainment of drug intoxication suicides, and thus for suicide surveillance, etiology, prevention, and the evaluation of mental health interventions. Without evidence from psychiatric records or psychological autopsies, decisions about the intent of poisoning or drug intoxication are subject to biases and open to default decisions by medical examiners and coroners, such as assigning the manner of death for drug deaths as accident or undetermined. In conclusion, for manner of death assignment, suicide requires substantial affirmative evidence. Affirmation of drug intoxication suicides by medical examiners and coroners appears to demand an especially high burden of proof or corroboration, most notably the presence of a suicide note as the voice of the deceased and, to a lesser extent, a record of psychiatric problems. Study findings and their implications argue for more stringent investigative standards, better training, and more resources to support accurate and comprehensive case ascertainment as the foundation for developing evidence-based suicide prevention initiatives. Thank you for your time and attention.